Assalamu alaikum wa rahmatullah. This is our first lecture in protozoology. We'll have to deal with the lumen dwelling protozoa, which are present in the intestine or in other viscera. These are examples of the lumen dwelling protozoa, which we'll study in this section. These protozoa are generally characterized by worldwide distribution, intestinal protozoa infections which correlate with the level of sanitation. Also, this include pathogenic, disease-causing, commensal, and opportunistic parasites. The first group is the amoebae. This group of parasites includes genus Entamoeba. This concerning Entamoeba histolytica, the pathogenic, and the commensal ones, Entamoeba coli, Entamoeba gingivalis, and Entamoeba hartmanni. The other commensals are Endolimax nana and Iodamoeba buchlei. These also are of the family Endomoebidae. The free-living amoebae, which are Acanthamoeba and Nigleria, they may cause fatal central nervous system and other infections. They are also amoebae, but they can infect man under some occasions. Genus Entamoeba. This genus is widely distributed in vertebrate and invertebrate animals. It is characterized by a nucleus which has an inner karyosome and peripheral chromatin granules distributed on the nuclear membrane. According to the shape of these chromatin granules and the karyosome, we divide Entamoeba into several species. The first is Entamoeba histolytica. It is worldwide distribution, infecting about 10 million persons around the world, more prevalent in the tropics and subtropics and in crowded areas with poor sanitation. Clinical disease appears on a small fraction of the infected people, and the others look like healthy people, but they are carrying Entamoeba histolytica. They are carriers. Inhabitants, this parasite inhabits the large intestine where the active form trophozoites are present. I repeat the show again to repeat my words again. Now, we'll have the life cycle of Entamoeba. Trophozoites in the large intestine may invade the mucosal crypts, feed on RBCs and form ulcers, or they may be present on the mucosal surface only. During invasion, they may pass with circulation to the liver or other organs where they cause abscess formation, and this is called extraintestinal amebiasis. If intestinal motility is rapid, amoebae pass outside as trophozoites in diarrheic or semi-formed stools. With normal motility, they extrude food vacuoles, round up, and the nucleus divides into 4 nuclei. Then they secrete a cyst wall around and form the resistant quadrinucleated cyst stage, which is present in the environment and is the infective stage for intestinal. Infection occurs by swallowing the quadrinucleated cyst, the infective stage, with polluted food or water or with soiled hands. This is a diagram for the life cycle of amoeba. Amoeba is a direct life cycle. As we say, this is the cyst coming out from the intestine, and it goes again into the mouth cavity with contaminated food or water and passes down to the intestine where it forms the trophozoites and colonizes in the cecum and ascending colon mainly, but it can go towards the whole large intestine. It may penetrate the intestinal mucosa, goes with the portal circulation to the liver, then to the lung, then can reach also the brain to form abscesses. The abscess is formed by the trophozoite, which lyses the tissues around and makes it look as a fluid content of the abscess. With secondary infection, it aggravates the condition. Here we can see that the cyst transforms into trophozoite. The trophozoite then multiplies by binary fission and begins here to round up and divide the nucleus. Then this is the quadrinucleate nucleus cyst, and this is the mature cyst which is present outside the body. Morphology of entamoeba. Trophozoites vary in size from 12 to 60 micromillimeter. The average size is 20 micromillimeter. In fresh stool preparations, they are actively motile in a directional movement towards the main pseudopodium. Movement by pseudopodia, these come out from any part of the cell surface. They are formed only by the outer hyaline cytoplasm, and the shape is blunt or finger-like, and the whole cell then fills the pseudopodium, and movement is directional, as I said. This is characteristic for entamoeba histolytica. On the cell membrane, there are endocytic food cups or phagocytic stomata. The large ones are for bacteria and tissues, and the small ones for pinocytosis. Food vacuoles characteristically contain red blood cells in entamoeba histolytica because it lyses tissues and feeds on the lysed tissues and RBCs. Nucleus is characteristic. The nuclear membrane is lined with fine chromatin granules, so appears as distinct line. The karyosome is small and central, and sometimes there are fine fibrils between the karyosome and the nuclear membrane. Pre-cyst stage has single or double nuclei, and the food vacuoles are extruded and the cell gets round shape. The cyst is surrounded by hyaline cystole, which is usually spherical. It is about 10 to 20 micromillimeter in diameter, containing 4 small nuclei, rod-like chromatin bars, and glycogen vacuole may appear early formed cysts, but disappear in old cysts, seem to be consumed by the cyst itself. This is the trophozoite of entamoeba histolytica. It is dividing here with a pair of nuclei, but is not a pre-cyst because this is a red blood cell, another red blood cell here in the food vacuole. This is a diagram of the trophozoite with the characteristic nucleus here, and this is the ectoplasm, and this is the granular endoplasm. Here also is another active trophozoite with the characteristic nucleus, and this is a pseudopodium. Here are several trophozoites with the red blood cells stained dark, and you can see the characteristic nucleus appearing with the central karyosome. This is a cyst of Entamoeba histolytica stained with iodine. So here is the nucleus, and this is a glycogen vacuole which stains dark with iodine in fresh samples. Symptoms and pathogenesis of Entamoeba histolytica. The amoebic infection can be either asymptomatic infection, which ranges from 85 to 95% of the infection rate. Also may be symptomatic infection, which has intestinal amebiasis or extraintestinal amebiasis. Intestinal amebiasis is either dysenteric or non-dysenteric colitis, which is depending on the infection of the rectosigmoid colon, because when the rectum and sigmoid colon are affected, there is tenesmus and there is dysentery. If they are not affected yet, we have non-dysenteric colitis with frequent diarrhea only. There is also extraintestinal amebiasis, which is about 5% of symptomatic cases. يعني 5% من 5 ل 15%. يعني it is very rare. It occurs either hepatic, which is the most common, with acute non-suppurative hepatitis or liver abscess, and also there is pulmonary amebiasis and other extraintestinal foci, which are very rare, and the commonest of them is the brain affection or central nervous system amebiasis. As we said before, that asymptomatic infection is the most common form of intestinal amebiasis. Amoebic colitis is the case when there is diarrhea, abdominal cramps, flatulence, anorexia, weight loss, and chronic fatigue. Amoebic dysentery بقى is the case when there is blood and mucus in stools and tenesmus. This in addition to the previous symptoms, which are the abdominal cramps and diarrhea and flatulence and anorexia. Sometimes I note you that sometimes the asymptomatic cases transform into symptomatic either amoebic colitis or amoebic dysentery when their level of immunity drops due to any cause, even if they have influenza or flu. When amoebae invade the mucosa, they cause minimal inflammatory response, so they cause minimal constitutional response as well. They secrete proteolytic enzymes, which causes necrosis of tissues, and so they can invade the mucosa. This occurs mainly in the cecum, less frequently in the rectosigmoid mucosa, and then in any part of the colon, especially in the flexures of the colon, and diffuse inflammatory response follows due to secretion of enterotoxin by the amoebae. Thus, diarrhea varying from 3 to 4 semi-formed stools frequently, alternative with constipation, and the more severe forms of colicky diarrhea and dysentery. Even so, the frequency of stools doesn't exceed 10 per day. If rectal mucosa is involved, there is tenesmus and painful spasms of the rectal sphincter, which is we call dysentery. Amoebae may penetrate the muscularis mucosa to the submucosa and spread and form the characteristic flask-shaped ulcer. They also penetrate blood vessels, so they cause bleeding, which accompanies acute amebiasis. Sigmoidoscopy shows tiny ulcerations with normal mucosa in between, and when there is extensive invasion, they may show larger ulcers with raised edges. Clinical examination shows mild or no fever, abdominal tenderness of the cecum, and also over the transverse and sigmoid colon. There is leukocytosis due to secondary bacterial infection, and this is the picture of the characteristic amoebic ulcer. We can see here, this is the aperture of the ulcer is narrow while the base is wide, and the amoebae are spreading here and here at the sides, because here the muscle layer stops them for a while and the mucosa is mushy and they can spread easily in the submucosa. Complications of intestinal amebiasis. First is perforation, and it is accompanied by the usual signs of peritoneal infection. Chronic leakage does not indicate surgery as in acute perforation. Secondly is granulomatous formation or amoeboma. This occurs with the repeated infection with amebiasis and formation of fibrous tissue, and it occurs in the cecum and rectosigmoid colon and looks like a tumor, and it is suspected as tumor at first, but it is later is diagnosed as amoeboma. Bleeding, which occurs due to invasion of bigger venules or blood vessels inside the submucosa. Sometimes stricture formation after healing of extensive amebiasis infection. Now we come to the extraintestinal amebiasis. First step is hepatic involvement. Hepatic involvement is either diffuse hepatomegaly without evidence of amoebic invasion of the liver, and this occurs due to the toxic response of intestinal infection, as we say that amoebae excrete some toxins. Then we have the amoebic liver abscess, ALA. This is characterized by enlarged tender liver, fever, because there is pus under tension, weight loss, and pneumonitis if the lower part of the lung is involved, as a spread from the right dome of diaphragm and the right quadrant of the lung is affected. Sonography and computed tomography scans can give a good diagnosis in case evaluation. Aspiration of the abscess gives thick reddish-brown fluid, which usually doesn't contain amoebae. Amoebae are confined to the wall of the abscess, invading healthy tissue. Pulmonary amebiasis occurs by direct spread from hepatic abscess through eroding the diaphragm, as I said before. Sometimes it may occur as a primary focus by blood-borne infection from an intestinal lesion. Usually the lower right lobe is involved, but the left lobe can be affected from the underlying left lobe hepatic abscess, which is less common than the right lobe abscess. Why this? This is because the right branch of the mesenteric vein is in continuous direction with the main portal vein. Rupture of the abscess through the diaphragm can cause pleural effusion and a characteristic X-ray picture. Also, rupture of the abscess through a bronchus produces reddish-brown sputum, and the amoebae may be found in the sputum. Other organ involvement with extraintestinal amebiasis, this occurs through hematogenous spread from lung involvement. Abscesses may occur in the brain, pericardium, spleen, and many other organs, and the clinical signs are according to the organ involvement. This is very, very rare now because even if anyone feels colic, he runs to take anti-amebic treatment, so the case is obscured and the complications are very rare. Cutaneous amebiasis, it is called amebiasis cutis, can occur directly in the anal and perianal region, also around a colostomy opening or draining liver abscess. There is extensive gangrenous ulceration of the skin, and the trophozoites can be found in the periphery of lesions, and this is also now. Diagnosis of amebiasis. Direct stool examination in acute amebic colitis shows the trophozoites and precysts also. Concentration methods for apparently healthy people can be used for stool examination in chronic and asymptomatic cases to find the cyst stages. Also, immunologic and serologic tests as indirect heme agglutination, gel diffusion precipitation, and enzyme immunoassays can diagnose. Prevention and control. Prevention of polluted water intake by boiling water or adding disinfectants in rural areas where there is no water sanitation. Proper washing of fruits and vegetables. Repeated examination of food handlers. Also, the use of prophylactic drugs as enterobiform must be prevented, as this drug can cause serious eye disease. Also, the use of Imodium lomotil to stop diarrhea may complicate the cases of bacillary dysentery, which may be confused with amebic dysentery.